so we are recording it. And it does not appear that there is anyone from the public. So we will jump right to attendance. Ram?
Present.
Bob?
Present.
Lindsay?
Good morning, present.
Patrick?
I am here. Good morning.
Morning. Ajit? Lauren?
Here.
Gian?
I think you called me. Yes, I'm here.
Yes.
Sorry.
No worries. Good morning. Rachel? Trina? I think Fred is here for Trina.
Yep, that's right.
Susan?
Present.
And Jen?
Here.
And I see Rachel has joined us.
Present.
So we have a couple guests with us today. So Sumit from the Office of Health Strategy is here. I don't know if we should do introductions. There are a lot of us here right now. But we can, I guess we can do introductions as we get to that part of the agenda. Unless somebody thinks otherwise. Okay, great. All right, so the first item on the agenda is consent management. So this is a topic that has arisen at a number of meetings and was brought up during our last executive board meeting. So we thought that while this is a new concept for many of us, it's obviously something that's going to it's obviously something we're going to need to take into consideration on a number of fronts for P20 and so we have, so Susan is here from DSS as always, but to talk about consent management as well as Sumit. And I don't know who I should put on the spot first, Susan or Sumit. How about Susan?
Sure, put me on the spot. Well, I think I can more just kind of warm up the issue, whether or not, I can necessarily, kind of take us to the finish line on this. But certainly, as Katie indicated, my commissioner was one of the folks that raised consent management at the last executive board meeting, and obviously, I'm sure, obviously for other agencies as well. But some of our data is extremely sensitive, and thinking about how do we ensure that we're protecting those data and instilling trust on the part of the folks that we serve. So wanting to think about how do we introduce that concept within the work that we're doing here in P20. I'm also recognizing that there are a variety of statewide initiatives that I think also would benefit from some discussion related to consent management. So I think about the MyCT work, Sumit here. Also, I think about some of the work in the solutioning potentially for the collection and reporting of race ethnicity data, language data. So I think I thought it was a good time and this being a good place to maybe talk about where do we go with this? Do we want to surface a work group to kind of think some of this through, just really to make sure that we've kind of dotted our I's and crossed our T's on this, and thinking about the emerging resident advisory board and the role that body might have in supporting some of this as well. So this is more of a tee off. So, Katie, I can chat a little bit more about concepts, but I think at least this is kind of some of the nascent thinking about where we might want to go with the consent management work.
Excellent. So Sumit, do you want to run with that?
Sure. So, even though we say consent management's new, it's really not new. Many people in the state that I have spoken with at various agencies have been working on consent management 10 years, 5 years, a long time. So the first recognition is it's a complicated thing to do. And it's not complicated because of one or two reasons. It's a variety of things. It's because there are a variety of laws. It's because agencies have their own mandates. They're different owners of data. You don't have a separate broker outside of the agencies that is coordinating the actual moving of data based on certain laws or based on certain rules. You don't have a mechanism, and I think technology has evolved now where there are a number of consent management tools that sit outside of agency systems. So I think from a timing perspective, it's the right time. So there are a variety of things that weave us into this complicated, and Susan alluded to a number of other projects that are going on, which are relevant in terms of even leveraging those initiatives with consent management efforts that we might be doing. We have, for those of you that may not be aware of this, we have formed an HHS interagency work group, which essentially is it's not statewide in the sense it doesn't include every state agency. It includes Health and Human Services state agencies, and what we've created is this work group that would, one of the things that we're looking for is for this work group to pursue consent management. What we also want to do is leverage the work that's already been done. So instead of starting from scratch, instead of saying as though we're going to pursue this brand new, lot of work, pilot projects, documents, people who have expertise in this, anything that we can leverage to move the ball forward, we want to do that. So we don't start from scratch. Some of the key concepts that I have in mind, we need to have clarity on trying to minimize the scope first instead of trying to handle it at a statewide level. So instead of taking every HHS agency and saying we're going to create a work group to go pursue consent management, what we're hoping to do is create smaller work groups that look at 3 or 4 different agencies to identify a variety of things. What data do they have? Are they the owners of those data? What rules or laws impact those data? What are the requirements before anybody else from a different agency could see that? Do we need some type of a client consent, or is it a circumstantial consent, i.e. depending on what you're applying for, maybe through another agency, the law allows you to see that data. So there are a variety of these questions that have to be answered by the work group. And we want to do that underpinned with some use cases, i.e. we don't want to connect data just for the sake of connecting data. We want to connect data where it would be valuable. So somebody at an agency that's saying, I could use another agency's data, they have to demonstrate some use cases to say, if I had the other agency's data, and if that data included these 10 data elements, I could either be more efficient, I could provide better services, these services could be coordinated, I could refer the client to additional services if I had known these kinds of things. So you have to be able to connect the dots and say, we're doing this because there is some benefit associated with it. We're not doing it simply because we think it would be interesting or I would get a bigger picture of the client, but it doesn't translate into something measurable or something objective in terms of either efficiency or client services or other kinds of benefits that we can identify. I also view this as the agency that owns the data really needs to be primarily driving the clarity of what are the things that you need to have as a different agency to be able to see this data. So you know your data, you know what laws apply to your data, and ultimately you're the one releasing the data to another agency. So it would be that agency's responsibility to identify the list of things that another agency must get in terms of consent to be able to share that data. And then we need to find a mechanism of making sure that at the time that that consent is received, that can be shared with the source agency or the agency that owns the data so they can then appropriately release the data. These are not new concepts. So the federal government, as part of the CARES Act from 2016, recently just published, now this applies more in the healthcare space as in EHR systems. They have published a concept paper on applying the CURES Act interoperability and how do you get consent where you're trying to connect multiple different HIEs together. So the concept I'm hoping to leverage is that federal concept and some of the work that's already happened in the state. The final thing I would say is this isn't going to get solved tomorrow. We've been at it for a long time. It's going to take some time. It might be starting with a microcosm and then expanding it to other agencies, might be doing some pilot projects and then expanding it to other agencies instead of, hey, we have a 1-year project or a 2-year project where somehow this consent management has been solved and we move forward. So these are just some of my thoughts. They're not set in stone. I am hoping to collaborate with anybody that would like to provide some feedback or be part of this group. So I welcome all of that. And I already see Scott has his hand raised, and I'm not sure if that's to volunteer to be in this solutioning or if that's a question, but either ways, I welcome it.
It's a question, but I'm happy to volunteer too. I wanted to ask maybe, I think mostly for Susan a little bit, also for Sumit, if you can go back and just talk about a little more why this is something that DSS has as a particular concern. And I think to Sumit, your point, it's not a new discussion. It's new for, I think, it's new to this effort because in the longer term, I think particularly P20 wins relied on some of the exceptions in federal law that allow for the sharing of data without consent. And there's nothing that this discussion is not in any way, I think, trying to reverse that. But my understanding is that there's some of the programs that DSS offers, other agencies that are in the health and human services space particularly, but it's not limited to just those. I think there's cases outside of health and human services as well where consent is important to gather for the safe, ethical, secure sharing of data. So it's not changing the fact that there's cases where you can share data without consent, but I know that there are cases where that's an important factor that would permit the sharing of data particularly for DSS, but and that's why you guys have raised it. But I think it might help to spend just a second on that so that folks understand the cases when you can share with and without consent.
Yeah, certainly. There's certain health conditions that we're not able to share. So HIV data generally, or substance use data, some behavioral health as well. So in those instances where folks may be wanting those type of data, we would have to have a consent. So we want to be kind of proactive and thoughtful about if that's the kind of data that someone may be requesting, we do need to have some kind of a consent management process. So just internally, when we get requests from outside researchers and they're wanting those data, we do have to work with them on some kind of consent process and some consent management. And it can get obviously quite wieldy to do that. When you're talking thousands of records and things like that, and making sure that, the consents have been executed properly and that they continue to be valid, over the course of, what could be years of research. So, those things are definitely challenging. And so when we think about this in relationship with other state agencies, pulling together who may also have their own, consent needs, that also, it really is something that I think we need to, and again, it's not that we haven't thought about it, but I do think we have to have a little bit more of a forward plan in terms of doing this. And thank you, Scott, for also talking about this on the kind of the ethical side of it. When I think about it, it's, we have the technology piece and the platforming and the management. We have the, the legal requirements, but also kind of the ethical pieces, which I think also we have to be thoughtful about in terms of, how do we also bring that factor into this and thinking about, really what triggers a consent in addition to it potentially being legally, but are there sometimes also kind of ethical places where we're saying, yeah, you know what, we do think we want to go down a consent route because of this, the sensitive nature of this, also, understanding, some of the historic issues regarding trust So I think that also has to be surfaced as part of the discussion and thinking about what's the appropriate mechanism to consent management. And even some of the work thinking about just generally about kind of what's the general kind of thinking about this, what's our value proposition related to this, may be a good place to get some consensus in addition to thinking about how it impacts each of us kind of differently. But I think that there are, certainly some things that hopefully we would all kind of pinky, as my nephew's always pinky swear on, that these are the kinds of conditions that really would trigger, consent. And then we, kind of reverse engineer back about kind of, well, what's the best way that we actually implement it, and what are the mechanisms that we would employ in order to do it well and right. I hope that got you where you wanted to go, Scott.
Yeah, thank you.
Okay.
I think another thing I would add is all roads, at least in the HHS space, seem to lead to DSS. Every agency that we have done these one-on-one calls with, and again, I understand that this data governing is not limited to Health and Human Services. I just speak more on the Health and Human Services side because Office of Health Strategy is just focused more in that space. But we have had multiple conversations with HHS agencies, and the most frequently asked for data because of Medicaid reasons is DSS. So we're certainly planning to include DSS in the early participation for consent management because there's just so much interest in getting that data. I also wanted to point out that I've heard this, and it's not broadly said, but it's not going to replace DUAs because the underpinnings of the consent is still going to require some type of an understanding between entities on what data is going to get shared, if it's going to get shared, under what circumstances, how that data can be utilized, whoever you're sharing this data with, how they need to protect it, who within the receiving agency can see it, cannot see it, and what consent mechanisms the receiving agency must have in place in a trusted relationship to then say, yes, when I'm demanding it and I'm telling you that I have consent from the client to see this, the sending agency can have the confidence based on the DUAs that is in place and that everything's happening appropriately. So consent management's not to replace any kind of data use agreements. It's really a layered on top of that. So it's just executing components of what is in the DUA.
I see Rob has his hand raised.
Yeah, good morning. Thank you, Sumit and Susan, for bringing this up. I think it's a really important area that we need to talk about, and I think it's a great idea. I think that when I think about consent management from a workforce perspective, I think about how important it is to our participants on that level itself. And I know that, we're using, and, at this level, we use data for a lot of reasons, for analysis and purposes along that line. But when I think of it for the individual. And what I can tell you is that, of course, when you run federal programs like we run, the data that we have and we share, we need to make people eligible for our programs. And without that information, it makes it very hard for a customer to be able to verify the information that we need to put them in the program. It would be wonderful if we could engage together as a group of agencies, all agencies, to form some kind of a consent management program where we're not constantly asking our participants to complete consent management over and over and over again, which I think is probably one of the greatest concerns that I can share with you when I work with the workforce development boards. That's one of the things that they're always talking about. The second area I really want to point out is the fact that with consent management, we are able to better serve in knowing things through consent management in the workforce arena. We are better able to serve our participants so that they are successful going forward. workforce is a culmination of removing all the barriers that an individual faces in order for them to be successful. And in order to do that, very often it is better to know the barriers that an individual has so that we can provide them with the kind of support that they need to be able to remove those barriers. So I'm really happy that this is getting a discussion that's going to be like a statewide discussion, because aside from, I understand where you are, I understand we're all here for data, but aside from data, I'm saying that there's a real impact on individuals and us being able to make the most of the money that we have. We have very little money that goes into workforce programs from the federal government. To make the best of that, to be able to know what barriers individuals have so that we can work with them is extremely important. So I think that if we could work together on some kind of a consent management, that would be excellent, but it really should be statewide, because again, the biggest complaint I hear is that I'm constantly filling out the same information over and over again from each state agency that I speak to or I talk to. And, we had this discussion yesterday in regards to ethnic bias on another call I was on. And, the problem with that is too, how are people answering those questions, right? So the federal government may include 4 ethnic types. Another agency may have 6. Another agency may have 7. So when we talk about, all of that, that gets very tricky too. I just want to thank you for bringing this up to the group. It's excellent.
Yeah, Robert, I think those are excellent points. I don't want to volunteer anything from the MyCT or folks from BITS, but I think one opportunity we might have to at least have an initial conversation and see if we can leverage, as we get critical mass using the MyCT portal, which is where, if we're going to expect Connecticut residents to go apply for services, could consent management be received at the time you are in that portal and applying for services? And does that become sort of a broker or keeper of consent management? And maybe it requires an annual reconsenting on things. And I don't know what the appropriate time frame would be. I'm just throwing a milestone out there for consideration. And again, I haven't had any conversations with MyCT on the possibility of doing this. It's just, as you were talking about, hey, we keep asking clients again and again for consent. Maybe there is an opportunity for us to leverage that type of a portal. And initially, maybe we're not going to have enough critical mass for people to go through that portal, and maybe that's just going to be an additional avenue to gather consent. But as more and more people use MyCT, maybe that becomes a primary source for us to ask people for consent. And, particularly if you're applying for services through that portal, maybe there could be a checkbox or a mechanism there with appropriate questions to gather that information. And again, I'm speaking beyond what I have right to say, because I am not running the MyCT project, and I have had no discussions with MyCT project or BITS on this. Manisha, I see you have your hand raised.
Hi, good morning. Great discussion. I think I'm finding myself a little confused though, because I always thought consent management is to help with the individual and, to just have, so the case manager working with them has a broader sense of what all, barriers, just like Rob was talking about, that they're facing. But I feel like the conversation might be veering a little bit towards consent management so that you can fill out the information one time and enroll in multiple programs, which I think is separate. So I think we should be careful. We would love to have, fill out the information one time, get enrolled in multiple programs. I agree. But do we want our consent management work to go in that direction, or be just, again, really focus on the individual, their needs, what the case manager could, information for the case manager that could help them help the individual?
Yeah, I think the primary focus obviously has been, can we find opportunities for either efficiency or greater service if we had the broader view of the client. So that's really the primary purpose. And how do we find opportunities to make it easier for people to provide us that consent and record that consent? Because I think part of it also is we need to have easy access to that consent when we're asking for it, and we need to make sure that we're not repeatedly asking for it. So I think the purpose is still what you described as the case manager being able to provide better services, better referrals. But I think how do we execute that is an interesting question, and all of the technical opportunities or avenues that might exist that we can leverage to undertake that. And I think some of these solutions are going to come out of that work group. And, I think part of what that work group's going to be doing is understanding the challenges, understanding the opportunities, understanding the work that's been undertaken, understanding the laws that impact the data and what data are we even talking about, and then make some recommendations, and initially some broad recommendations, and then more specific implementation recommendations that can translate into some projects with specific scope and money and resources to execute.
So we have a couple more. We have a few hands up. So Susan, and then Ram, and then Jan.
Trying to get off the mic. So yeah, I think, Manisha, much to Manisha's point, I think we do have to be very careful about kind of what kind of consent we're talking about. When you're talking about the consent someone might need specifically from an agency where they're getting some support, direct support, that's very different. That's a relational thing. We need to be thoughtful about some of that. But I think there still needs to be some way of people being able to kind of manage that and knowing, kind of the various places in which they have been given certain levels of consent related to access to, their direct medical records and other providers and things like that. When I think about, just also the technology, even on the side of people giving consent to share their data, I think, again, we should have some technological solutions where folks can have it almost as like kind of a passport and understand, the types of projects and where they're and how they're giving consent for different things. But it's also the timing of that I wouldn't want it to make folks think that it's almost coercive. I have to give this consent or I might not get my benefit. So I think we also just have to be aware of that. I just, I know that's probably a little bit, we don't need to necessarily surface that right now, but I just feel obligated to kind of think about that, maybe it's after someone has actually, gotten the benefit and then they get a, some kind of an email back saying, hey, would you like to consent, blah, 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 but not necessarily tie it to, because folks might not feel that it is actually something that they are able to decline. So I just want to make sure that we're thinking about that too. So thank you.
So yeah, if I could, good morning, everyone. I just wanted to piggyback off of Rob's comments, because I've seen that multiple times, throughout my 25 years, plus with state service, that people are coming in for services and they have to fill out the same forms, whether it's in one agency 3 different times, and then the same, they need services from other agencies, and they literally fill out the same paperwork. And so what ends up happening from a customer's perspective, someone's looking for a job, they need help from 4 different agencies, and they're filling out the paperwork, they get completely frustrated, and then they disconnect. And in a sense, that's a disservice for the customer. So I think that's something that's important to be able to try to find those efficiencies, understanding and appreciating, that not everything will be available, but where we can, find those efficiencies so that we can help the people that are in need as quickly as possible. The other point that I wanted to just touch upon really quick, what Rob said with regards to the consistency in data when people are asking for race or other matters. One organization has 5, another organization has 6. We had that similar discussion, within the college universities yesterday. So it's important, if we're trying to do research projects, that we're measuring things, the same way. So that's something that I think that we should also be looking upon. Thank you.
Katie, can I just address the race, ethnicity, and language part of the question? So I'm glad you brought that up. We have a new statute, a public act in Connecticut effective January 1st that requires any of the agencies as well as providers in the community, and it doesn't matter what type of provider you are, as long as you have an EHR system capable of connecting to the HIE, you are required now to have standardized race, ethnicity, and language data elements, and the standards been published by OHS. This is effective January 1st of this year. We understand it's going to take some time to ramp up to that. In fact, we're working with agencies. We have 8 or 9 different agencies that are impacted by this public act, requiring them to upgrade their systems to make sure that it is following the standards. So I agree that data standards as part of consent management or related to consent, I shouldn't say part of consent management, but related to consent management, data standards are going to be critical, because if we're sharing data, we need to make sure that it's consistent and the receiving entity makes the same sense of it as the sending agency. And the reports and other places where similar data exists is being reported in a consistent fashion. One of the key requirements for consent is going to be sending, if you have received consent and now you're trying to pull data from another agency, it's going to be important to send some demographic information to match the individual. And that is also where consistency is going to be key, because otherwise you're not going to get good matching. But at least on the race, ethnicity, and language, I wanted to plug in, put a plug in for the new statute that we have in place, and we're working on getting that implemented across the state of Connecticut. And any of the agencies that are impacted by it, we're happy to work with you on trying to develop an implementation plan. There is also, in collaboration with OHS and Connecticut Health Foundation, convenings on race, ethnicity, and language, which are monthly meetings that are taking place that help develop a roadmap for all of the impacted participants on the race, ethnicity, and language.
So thanks. I'll just jump in. I don't have a crystal clear question. Rather, I'm just noticing something, and I want to just sort of air it for the group. And that is this, P20 was founded to enable data sharing between different agencies for the purpose of answering particular policy questions. And we were not looking at case management. And this discussion right here is connecting the work, I think, of P20 to larger state data initiatives that go beyond at least the current purview of P20 in a way that it's becoming kind of clear. I'm just wondering, maybe it's a question for Scott, like, what is the direction for this group? Are we heading towards a case management, service management sort of a model, or if you could illuminate, elaborate, maybe it's a conversation for another day, but I'm just noticing a particularly strong shift in purpose. Thanks.
I'll cover a couple of the pieces. I don't think there's a shift in purpose. There's still a statutory basis for P20 It's to inform sound policy and practice through the secure sharing of longitudinal data across these agencies to ensure that individuals successfully navigate supportive services and educational pathways into the workforce. And I think the discussion today is consistent with that. It's about the secure sharing of data across agencies. I think you're exactly right that, the discussion, by the nature of it, has, blossomed into a couple areas that are related, but not sort of the direct purpose for this effort. But I think, providing information to the people who are providing data about how their data will be used is consistent with the purpose, providing avenues to ensure that we can, safely, ethically, and securely share data across agencies. That's part of what the consent is. I tried to put, I'll cite this because I'm talking, but I put in the chat an example of this for the state's rental assistance programs, not a P20 win. effort, but there's a clause in the agreement that tenants sign that that indicates that their data could be used to be shared by state agencies, how that would be used, and there's consent. Through that, how you manage that, how you track whether those have been signed. I think those are some of the practical questions that part of what Susan's question is bringing up. How do we do those things? But I don't see it as a it's not where this is not running a case management system. That's definitely not the case. But I don't see the discussion as a divergence from the stated purpose and mission of it. Rachel, you had your hand up. Sorry.
I did. I was just going to add too that I feel like since I joined the group when I joined the state, I've been raising questions like this for a long time about doing periodic data matches to create a data set so that we can just understand the pathway or the life course experience. And from where I sit, that's there's almost impossible to do with our service population unless we make some of these matches. And I'm not singling out other colleagues, but like Ajit and I have discussed, periodic matches that become routine matches. So, but that's not to say that it's a case management approach. There's nothing that I'm going to do necessarily to intervene if we see something down the road, but that kind of data matching helps us inform policy decisions. So I see it as like an absolute imperative of the work.
I appreciate your comments. Thanks.
Any other questions or comments? If not, we can move on to the next item. Thank you, Sumit and Susan, really for having this conversation with us today. I know that Susan and I had talked briefly about setting up a small work group that could meet as needed, just to see if we can help connect programs or help identify how we can move this forward. So if you're interested, you can let me know offline, and we'll make sure that we stay connected with Sumit and his efforts. So thank you again.
Thank you, guys. Thank you for having me.
So the next item on the agenda is the proposed revisions to the enterprise MOU. So as a result of a conversation at the executive board meeting, there was interest in streamlining the process to onboard new agencies to P20 WIN. And so we have sent all of you that language, and so the other so that's a revision to Appendix 1. The other language change is really just clarifying language to Appendix 2 to match the work that had been done for the incident response plan, and to just acknowledge the role that the Office of the Attorney General plays in breach notifications. So this is an opportunity to have a discussion, and we hope that the group will recommend that this language gets sent to the executive board for approval at the May meeting.
Katie, do you want me to put the slide up? We don't have to. I'm just
So the slide doesn't actually have the language.
Have the language. Yeah. Okay. Happy to screen share if needed.
If you want to. This is a new attempt to facilitate more conversation by not always sharing slides on the screen. So if the slides will help, we can definitely do that. But if you have comments or questions about the language changes, please, this is an opportunity to talk about it. If nothing, I will assume that you all are in support of this.
I'll just report for Trina. I know she reviewed it and had our legal folks review it, and they didn't see any issues with it. So we're good from DCF's end.
Thanks.
No problems here. I thought that the changes were logical.
Great, thank you. Okay. Excellent. That was great conversation, guys. All right, so then, so we will share this language with the executive board for them to vote in May. So thank you again. And if you have any questions that you want to bring to me offline, please feel free. So then the next item on the agenda is our technical upgrades with the SFTP configuration. I'm going to let Scott take this.
I'm going to let Bob take some of this. So there we go. All right.
Morning, everyone. Yeah, we had a meeting I think it was this past week, with the support for the SFTP and Axway support team, and kind of shared with what we're attempting to do. So that information was sent to the team. They're analyzing it now, and we'll be working with the vendor to get best practices and stuff going forward. So.
I'm going to add one question here because it reminds me of something that we discussed in the meeting. I know other agencies use the state SFTP tool, and I'm particularly looking at Susan, who's on my screen, that there's use from DSS. If there's ways that folks are using the tools that you feel like we should know about. I know there was something where there's sort of like the ability to use email for some of the notifications about the SFTP configuration. So if there's anyone that's an active user of the SFTP tools from one of other agencies outside the context of P20 and you want to forward something, there's some documentation that DOL shared on the configuration, the implementation that the Axway team's looking at. But it's always worth thinking, it was like, oh, somebody else figured out something else in a different agency, and understanding that. There was something I believe about like the ability to have an Outlook integration that I think was maybe through DSS, but that's where I just think there may be others who are using it in some fashion that deep within your agency. If you think of something, please say the word.
Yep. I'm not aware, but I can certainly go back and check with someone about that.
Yeah, I know we use it pretty often, but I can't think of any particular fun use cases, the ways we've applied it. Pretty standard, I think. But yeah, I'll ask around.
Okay, great. That's awesome. Thanks. So then moving right along, the next item, I guess you could share the screen for this. So my new approach for our data request calendar is just breaking down the requests that we have that are active by the learning agenda topics, and then those requests that are incoming or in review. So as always, these are our 5 primary topics that we're focusing on. If you want to go to the next slide.
Katie, it's just because you made such nice slides. I want the world to see them. So.
Okay, so not much change from last month, though we did have an update with higher ed yesterday about the Roberta Willis scholarship analysis. I don't know if Coral's here, or if she wants to give us a quick update on that.
Good. Okay, there we go. Hi. So we talked about Roberta Willis yesterday. Ryan, our intern, gave an overview of the work he's been doing with the UDR data, and we discussed what we could see in a future data request, and it would likely cover outcomes, both educational and post-secondary, and what outcomes we'd like to measure from those. And that was pretty much it.
Great, thank you. So we will have regular updates on that as we make progress. So thanks, Coral, that was great. If you want to go to the next slide. So, so these are the active requests. So we have the HMIS labor request. We have WestEd. The data sharing agreement is in review for both 33 and 34 and 35 down here. And then the CTech apprenticeship data request number 17 is we will be moving forward with that. We have had to adjust some of the data variables associated with it, but it's exciting that we'll be moving forward with this. Do you want to go to the next slide? And then these are the requests that we have received or are anticipating receiving. And you can see they cover a lot of different topics and relevant issues. And so I will, as we receive these data requests, I will be in touch with those of you whose agencies are involved.
Katie, this is wild. There's 2 childcare requests here that I have not even heard of. Can you tell us anything about those?
Sure. They're very recent conversations that we've had. So the child maltreatment outcomes is a research evaluation from 2 professors at Trinity College. And then I'll let Scott talk about the education system involved youth.
I don't think that one has early childhood. The child care and food assistance, I think, is through UConn School of Social Work, and so you may be familiar with it, and it's just labeled in a way that is not obvious.
Okay.
And I don't know.
Care for Kids assessment evaluation? We can talk offline.
Yeah, we could cover it offline. This is also like fairly early, I would say, but it's Integrated Care for Kids is the Inc. Project that's in New Haven that actually I think is through DSS, but we can provide some of the, I don't know, background information.
No, I'm always excited when people want to use our data.
We've had very early preliminary conversation. Yeah, so I don't think that I don't know that they know specifically. Yeah.
I was going to say the same thing about the maltreatment outcomes. Excited to see it. That's cool.
Yep, we are waiting for the data request to come in on that one. So. Anything else? And then, okay, so cool. So this is what we have in the queue. So I guess the last thing on the agenda is the learning session on April 15th. I don't know if a topic has been determined, but we will let you know as soon as it is. If you have ideas, if there's anything you want to learn about, hear about, who you want to hear from, please let us know. We're here to help you guys. So if nothing else, I can give you guys 9 minutes back on your Friday.
Have a great weekend, everyone.
Thanks so much.
Yeah, take care.
Thanks.
Have a great weekend.
Thank you.
Thank you.
Thanks. Have a great weekend, guys.
Thank you.